health service executive, who's going to be talking to us about physiotherapist confidence and training in autism, a UK and Irish survey. Okay, thank you.
Hi everyone. So we're looking at basically the confidence physiotherapists have and the level of training they have in autism, both in the UK and in Ireland. So essentially, to make sure I have this the right way, yeah. We kind of had two main aims. First aim was to kind of explore and kind of identify the level of training that physiotherapists have in UK and in Ireland. Now it is a bit different between the two. I think working in both the NHS here and also in Ireland, there was quite a bit of a difference between the two in the level of training that was provided. And then also the impact, kind of just identifying how important that training is for physiotherapists. And then we looked at kind of why we wanted to look at this and the purpose. So the importance of increasing accessibility for individuals or autistic individuals and making sure that they can actually access the services. There's a lot of, I think, apprehension when coming to any appointment. And I suppose that was kind of highlighted previously as well in the last session. So just making sure that we can make it as accessible as possible. And then to obviously improve this, we want to try and advance and continue to support the different trainings that are available for physiotherapy in the UK and in Ireland. So when we did our study, these were kind of the methods that we used. So essentially, we kind of did a literature review. We looked at kind of what information's out there. Now, over the years, it has actually increased. So that is definitely one positive. There was some kind of studies looking into the levels of training that's provided. But again, it is very, very small in comparison to a lot of other research areas. We went for a low-risk ethics application, just primarily because it was completely anonymous. We didn't actually have any patient contact, and we're working directly with physios, just filling out an anonymous questionnaire. So that questionnaire was developed on Qualtrics, and we gathered participants over February and March 2024. And essentially, that looked at kind of physiotherapists' confidence levels, and we kind of reached out to the CSP, and we also reached out to the Irish ISCP as well. So moving on. So I suppose it's kind of just to throw it out to you. I know you've answered a lot of questions, but what do you think we found? I suppose we just do a quick hands up as to, do you think that there was a lot of training provided or not too much? Okay. So in total, we had 602 physiotherapists that responded to the survey. Most respondents were female, and on average, they've been practicing between 5 to 10 years. And then the attendance on training and levels of confidence, it was actually, very interesting results that, over 50% of the physiotherapists had not undergone any official training, prior to kind of related to providing appointments for individuals with autism. And then informal training, because there's a lot of CPD that everyone does, especially within all different disciplines, that again, over 57, or around 57% reported, having no informal kind of training either. So when we looked at their confidence levels then, most responded as slightly confident or somewhat confident in being able to work with autistic patients. And then the confidence appeared to be rated lowest in their ability to communicate. And I think with this, just to touch on it briefly, is kind of identifying what that patient needs. And I think it kind of comes back to that preparation before your appointments to really identify, what level of communication needs those individuals may need or any kind of reasonable adjustments. So then we looked at the association between the attendance on prior training, and we just did some basic, very simple statistics, which came out to basically suggest that attending autism-related training may positively influence the confidence of physiotherapists, which I think most of us would hope would be the case. You don't want to be attending training and all of this and actually not have a benefit in your actual workday and helping people. So then just to go on to the conclusions, what we found, the main key findings essentially was many physiotherapists in primary care and community services had not received autism-related training. On average, physiotherapists working in primary care and community settings reported a moderate level. I think the awareness and the publicity of autism now has grown. So even if you didn't attend kind of formal training, you can somewhat, you know, look up certain things yourself. But it's really looking at making sure things are mandatory, that we can make sure that everything is accessible for people. And then the attendance of formal autism-related training was positively associated with improved confidence when helping autistic patients. So I suppose what's next? I'm implementing training initiatives, kind of making sure that there are things out there, there are trainings out there that can benefit, you know, autistic individuals and their accessibility, and making sure that you can make reasonable adjustments. I suppose just to touch on that a bit, it is very difficult. I'm not going to lie. So I've been in many different HSC buildings, many NHS buildings, and you can't dim lights. You can't reduce the noise in regards to a waiting room. So it's kind of looking at what is the best for that individual. And I think now, because it's more, we're more aware of autism, you know, there's no harm in asking either. You know, when you make those prior calls and that prep beforehand, and it doesn't even need to mention it. It could just be, is there any reasonable adjustments? It's kind of that simple question, just putting it into, you know, what you do, prepping up to the appointment. So yeah, you know, you can only do what you can do in regards to what you have available. You know, it's a case of trying to make the best of what you have. Future research. Okay, so we'd like to look at like employing some qualitative approaches, you know, I think speaking to and hearing from autistic individuals themselves as to what's worked well for them, to basically try and inform us as best as possible. How do we move forward to make sure that we make it as accessible as possible for them? And then I suppose to kind of make, you know, adjustments and understand how physiotherapists can improve their knowledge. You know, I think it's implementing that as well. I don't know about you, but I know a lot of people go to these like online trainings, and it can be challenging to kind of actually implement then what you've learned in the training. Also, just to add before I wrap up, this is not exclusive to physiotherapy. Okay, so it's just to kind of reiterate that, you know, as much as we looked into this, realistically, one study showed that only 25% of GPs and nurses reported having a high confidence in working with individuals with autism. So it's not specific to physiotherapy, and it's just something we need to improve going forward. So yeah, so if anyone has any questions or anything, I think we're having question session afterwards.
Very much.
Thank you.
Yeah, we'll do Q&A at the end. But yeah, so thank you. So next, so I'd like to invite Adora Okunu to come up onto the stage. So this is going to be a talk around investigating the minimum effective dose and effective rebound exercise in community-running adults with neurological disorders, a pre-COVID interventional study.
Hello, good afternoon, everyone. My name is Adora Okemo, a PhD student at Buckinghamshire New University. So this afternoon, I'll be presenting the study titled Investigating the Feasibility and Effect of Rebound Exercise in People with Neurological Disorders. Sorry. Okay, sorry. So, studies have shown that rebound exercise performed 3 times a week improves mobility in people, adults with neurological disorders within the hospital setting. However, it is not clear if the same outcome can be achieved in the community setting with less frequent exercise participation. And so this study aimed to investigate the feasibility of rebound exercise in people with neurological disorders living in the community. So the study was a prospective observational study in which 53 participants were exposed to rebound exercise, 30 minutes per section for 12 weeks. So the participants were allowed to participate any number of times during the week, but the weekly frequency was noted. The eligibility criteria was adults with neurological disorders who could walk for at least 2 minutes with or without assistive devices, who could understand therapy instructions, and who had no other significant comorbidities. The primary outcomes assessed were recruitment rates and retention rates and the number of adverse events. And the secondary outcomes were mobility and physical activity level. So on the other side of the slide is the flow chart of the whole process from recruitment to analysis. So 60 people indicated interest, and out of the 67 were excluded based on the exclusion criteria, leaving only 53 to be enrolled in the trial. And at the end of the 12 weeks, only one participant dropped out due to COVID-19, and we had 52 participant data analyzed at the end. Results of the study show that there was a high recruitment rate and a high retention rate, leaving a low attrition rate of 1.89%. So what this suggests is that the rebound exercise therapy is feasible and well accepted by the participants, the adults in the community. And again, there were no reported injuries or adverse events, which shows that suggests that rebound exercise is safe in this population. So that is a table showing the demographic characteristics of the participants, and the results show that majority of the participants were females, were married, were within the age range of 65 to 74 years, majority were retired, and majority participated once a week, and most of them were diagnosed with Parkinson's disease. On the secondary outcomes, so the results show that there was significant improvement in walking speed between the baseline and the 12-week test. And this is significant because faster walking speed is associated with increased independence and reduced risk of falls, especially in older adults. And again, there was a significant improvement in physical activity level between baseline and 12 weeks. And this positive shift in physical activity level is also very significant because studies have shown that low physical activity level is associated with increased risk of chronic diseases. Okay. So in conclusion, rebound exercise is a feasible, safe, and acceptable intervention for community-dwelling adults with neurological disorders, especially when performed at least once a week. And again, the significant improvement in mobility and physical activity level observed after 12 weeks suggests that rebound exercise may be a potentially valuable public health promotion to gear towards improving physical activity level in adults with neurological disorders living in the community. However, because this is just a preliminary observational study, more rigorous studies, especially randomized control trials, are needed to confirm the effectiveness of rebound exercise in this population. And we're in the process of seeking funding to carry out the effectiveness, the randomized control trials to confirm the effectiveness of this exercise in the population. Thank you very much.
Right, if I can invite, Ben, are you standing in or who's coming up? So all the speakers come up. Do we have any questions? Why don't you come over, sit down here and I'll move along. So then we've got the mics. Nearly fall off the back of the stage.
You ready for me to go?
Online questions? Or?
Okay, I've got a question for Adora. Can I ask why the inclusion criteria of someone who's mobile for 2 minutes? Because I know we do rebound therapy for people who are wheelchair users. Just interested in why that was the criteria.
Okay, because one of the outcomes that were measured was walking speed, and I used 10 minutes walk test. So at least you should be able to move for 2 minutes at least for you to be able to do the test with or without assistive devices. So that was the major reason. Yeah.
Do we have any questions online? Okay.
I had a question. I think you kind of covered it in your further kind of the thoughts about the next bit of research. It'll be interesting to see how people with autism feel about those encounters, because some of those people might say they feel really confident with the way they're communicating with people, but does that translate to a successful outcome for that individual? And I just wondered, do you have any ideas how you might study something along those lines?
Yeah, I think it needs to be collaborative with both, to be honest. I don't think you really need to find a physiotherapist that's willing to engage in research with a patient of theirs. So then you can see if there is an outcome for both. I think that would be, in my mind, the most reasonable way of moving forward. So you can kind of get both perspectives. I think the biggest challenge with that is time. You have very, very heavy caseloads and a lot of patient waiting lists. And to try and add in, say, even an hour interview in a qualitative way, that is going to definitely impact not only physician's time, but us, that individual as well. So I think kind of moving forward, that would kind of be the way, or even just looking at maybe specific teams. So try and keep it within a team basis. So which means then, as much as the study will be small, at least you can really relate between the patient and also the physiotherapist.
Thanks.
I've got a question for each of you, actually. I don't know if this is on. If you had a wish list of what you would like as the one thing, what would it be to help improve for your population? It's not working, but you first.
I think it is.
Is it working? Oh,
Yeah,
yes,
yeah.
it is now. Okay.
Oh, that's a good question. I think just awareness is just key, and the broader that we can get that awareness, the better, because a lot of people don't have that knowledge of our population, and that's really our ambition, I suppose, as the ECPPLD, is to get that message out there. That's very broad and vague, but I think that's what it has to be.
Well, we're all aware in this room, so we have to all go and pass the message back. What about yourself?
I think for me it would be, making it evident. So, in especially private, I found in Ireland, like, there isn't really any information or even just words, there's nothing actually physically there to say that, you're an autism friendly, physiotherapist, or, that you can make those reasonable adjustments. So it's kind of just having that extra level of communication and the kind of you're being proactive about it instead of kind of reactive. So I think for me that would be one of the major things, because if you come into something and you don't recognize that somebody is aware of this, then you're less likely to communicate your needs and what reasonable adjustments you would like in place. So I think for me that would be the first and foremost a good starting point.
Anyone else?
Okay, just to add to what you've already said, mine would be funding. To get adequate funding to be able to carry out innovative researches that would help public health promotion efforts in the end. Yeah.
And I think mine will be kind of further on from what Amanda said, is putting it into undergraduate prospectus for all healthcare professionals, not just physios, but OTs and everyone like that, because that will just increase the awareness of the next kind of generation of therapists and healthcare professionals coming through. And it would mean that like these kind of bits of work just wouldn't be necessary because it would just be embedded the whole way through people's kind of career. So I think that would be really good.
Just before I come on to yourself, a question is then, do we know if the Oliver McGowan training is in higher education institutes? Anyone aware?
I don't know.
Might be a question for us to go in.
Do we have anyone from higher education?
I was going to say it's part in higher education now, so most places are doing part 1 in the Midlands, but the difficulty is part 2 and finding people who can do the training and it's trying to link it with partners. So again, I think that's a plea to anybody who is an Oliver McGowan training provider to do that part 2, get in touch with your HIs. We want to deliver this, but we need access to service users as well as the trainers, so please get in touch.
I think for me, the shift away from being really reactive as a NHS to actually managing people's disability and giving opportunity. We've talked about health inequalities a lot, haven't we? And actually getting in there early with some of these things rather than picking up the pieces. I think that would be the biggest thing. You know, in learning disabilities, we're managing their disability and giving them, trying to give opportunity for physical activity, etc. And that would prevent a lot of the falls and mobility and complex disability problems that we see down the line.
Perfect, thank you. Oh, and we've got another question. 2 questions.
Oh, I've got the mic. Yeah, well, I suppose a couple of questions. So the first one is, because in my workplace, one of the challenges is around where different services or service leads may work with their teams and where they can draw the line of what's reasonable when we're talking about a reasonable adjustment or not. And I just wonder if you've got any advice on how services can best make that determination on it, because it's quite subjective and it's a term that's been mentioned quite a lot today without us perhaps really defining it and digging into it. So that's the first question. And then I just wondered whether, do you feel that reasonable adjustments is the answer to us building accessibility and equity into services by design, or is it actually another reactive thing when we talk about being proactive? So is there more that could be done at the front end to make sure that services are more accessible for everybody before we get to the point of saying we need to put in reasonable adjustments?
Who would like to take that one?
So remind me of the first bit again.
Defining where do we draw the line of
Where do
what's
you draw the line?
reasonable?
Yeah, that's what he said. I think it is really subjective. It's difficult to know, and I don't think there is a definitive line. I think certainly for us as learning disability physios, I think the fact that you've tried it first is the key. So it's whatever is practical within your setting. So other settings may be able to make further adjustments than you can, but if you've done what you can in your setting, then contact us for help or collaboration. I think that's normally how it works best. I think rather than saying, well, everybody, I mean, in an ideal world, we would want a level of standard that all healthcare premises and things can all meet. But I think the key bit is to try some of these adjustments yourself and have an appointment that you've got as far as you can, and then come back to us if that makes sense. Rather than just, well, I've seen on paper somebody's got a learning disability, so we'll pass it to the learning disability team. That's the key message that we're looking for, rather than a specific definition of what is a reasonable adjustment. Does that help?
I add to that.
You can use that one.
Yeah. I think for me, the main thing to focus on is your outcomes, to identify if what's a reasonable adjustment. You know, if you're not attaining the outcomes that is needed not only for yourself as a physician, but also for your patient, then reflecting on what might have worked and what might not have worked to kind of see what that level of, you know, reasonable adjustment is. And then it kind of sets a level of understanding for yourself as to what you can provide, which allows a realistic approach going forward to establish, you know, what reasonable adjustments you can provide for individuals. But I think focusing on the outcome, you know, if they're cancelling appointment after appointment after appointment, okay, what does that reflect on that? Why is that the case? And then that will identify the level of, you know, reasonable adjustment you need to put in place, if that makes sense.
And we had a question again.
Thank you. Thank you for your presentations. I just wondered if you knew of, or maybe I missed the first part of the presentation, but of hospital passports, and if those could, you know, kind of help inform those reasonable adjustments.
Yeah, I think again with sort of the hospital passports, it's about that sort of understanding what that person needs, isn't it? It's very individual, and kind of goes a little bit back to the previous question about sort of those anticipatory. We can only make adjustments if you know what they are, and I think the hospital passports and hopefully the reasonable adjustment flag that's going to be available will help sort of that. So then you'll be able to get that information, and when you see the person, you know, you'll know what they need to have a good outcome.
Thank you.
Oh, yeah, time for one last question.
Okay, thanks. My name's Jane Schofield. It's not really a question, but a comment. So thank you for all your presentations. I think as somebody who's a physio and who's also a carer, not for somebody with learning disabilities, but somebody with other health needs, then carers are really good source of information and advice for considering what that person needs, and that can be done in a way that doesn't take away their independence and their having their voice and their say, but that can really guide you as clinicians and as service managers to know how to accommodate that as well. I think that's really important.
Okay, thank you. So I'm going to bring this session to a close, but thank you to all of our speakers, and I think the key take-home message for us is to try and be anticipatory. I do like that. I'm going to try and think, and I also really like the idea of perhaps being a bit more public in saying we are friendly to, you know, whichever particular service need. I think that is almost like it's opening the door and giving people permission to come in and be their true self. So thank you all very much for a great session.